Good morning, everyone. Thanks, Dr. Sneha, for giving me such an opportunity. So we will discuss pediatric ocular trauma. So, objective to review the epidemiology of ocular injuries, to discuss a systematic approach to eye exam, to review common ocular injury and emergencies, to review preventive approach for ocular trauma. Now, epidemiology, one of the most preventable cause of visual impairment in the world, from sports to war bombing. Up to 40% of all ocular injury occur in person less than 17-year-old. Eye injuries are the leading cause of visual disability and non-congenital unilateral blindness in children. In some studies, up to 60% of pediatric eye injury occur during sports and recreational events. Other studies show that the home has become the more common place for injury. Male account for almost 70% of all ocular injury. Boys to girl ratio is 4:1. Any sports that include ball, rocket, sticks can be hazardous. Rough sports and projectiles including toys, guns, darts, stones, air gun, paints, and these are more hazardous. So comes the history. But if there is chemical burn, proceed to provide copious irrigation before history and physical examination. Then history, detail and mechanism of injury, where, when, how and what, symptoms, pain, vision loss, double vision, history of eyeglass, medical history. Then comes the eye examination. Visual acuity is the vital sign of the eye. External anatomical examination. Any deviation from normal anatomy, pupillary response, extraocular movement, visual field, fundoscopic examination, then fluorescent examination, slit lamp examination, dilated eye examination, CT scan or plain film can be taken. Now comes the EUA. EUA is the cornerstone of diagnosis and management of children who are unable to allow a comprehensive awake examination. The first part of the examination may be done in the office. This allows the examinant to assess vision, presence or absence of strabismus, refraction, examination of the fundus with a dilated pupil. Second part is to examine the kid under anesthesia. In suspected penetrating injury like trauma by stick or sharp object or suspected foreign body, always intubate the child so that foreign body removal or repair, if needed, can be done in the same setting. Proper consent to be taken before the procedure. Now the classification is closed globe, open globe. In closed globe, you may have contusion, lamellar laceration. In open globe, laceration, rupture, penetrating, IOFB and perforating injuries. Now comes to the lead injury. First, do eye examination, then tetanus prophylaxis. This can be partial thickness or full thickness. This may be associated with canalicular tear. So if canalicular tear, you can repair it with the intubation or silicone tube or 26 gauge IV cannula tube probe. So this is one of the my case. I repaired it with the 26G IV cannula probe and the results are satisfactory. You can see the tear film height in both eye is normal after operation and lid contour is also well maintained. So this is another case of near total aversion of upper lid. So this type of case to be repaired with tarsal to tarsal, muscle to muscle and skin to skin proper apposition as much as possible. This is post-op 2 week and then this is the post-op 4 month. There is a mild ptosis, not hampering visual axis and there is no lag of thalamus. So this is another case. So comes the corneal abrasion. Probably the most common eye injury visit in the OPD, usually present with pain, tearing, photophobia, foreign body sensation. Topical anesthetics, when applied for fluorescent examination, provide temporary relief. Treatment usually consists of topical antibiotic, lubricant, pain medication, and patching. So, conjunctival corneal foreign body, usually present with similar symptoms as abrasion. Important to avert the eyelid and rule out foreign body. Treatment involves removal of the foreign body and topical antibiotic lubricant. This is the conjunctival and corneal foreign body. This is an interesting case of bee sting injury. This type of injury or wooden or iron foreign body penetrating deep into the stroma should be removed in OT with proper backup for suturing. This bee sting was removed in 2 parts. This is a case of hidden foreign body. She was 2.5-year female. There was history of trauma by wooden material 8 months back and she was wandering hospital to hospital. Then finally I removed under GA without any trauma and without any ocular damage. So this is a case of conjunctival injury with suspected medial rectus trauma. You can see the elevation and adduction is limited in right eye. There was a conjunctival tear. So I posted under GA and did a wound exploration. MR was found intact. So I did conjunctival repair. Post-op oral topical steroid was given. No diplopia or any residual muscle damage after 2 weeks. So comes to the corneal scleral laceration. Usually sustained during penetrating or blunt trauma, corneal scleral laceration are repaired surgically. Most important preliminary examination component is to document visual acuity. Gentle USG to assess PS. Orbital CT can be used for suspected foreign body. So this is one of my case of corneal scleral laceration. This is scleral tear which I repaired. This is one of my case, 7-8 year already completed, and best corrected visual acuity at last follow-up was 6-9 part. So this is another girl, 6-year-old. She had got a trauma. She came to me after 2 months of first repair of corneal tear and traumatic cataract. She was referred from somewhere. Visual acuity at presentation was CFC. So I did membranectomy with synecholysis. Visual acuity post-op was 636. Now comes to the globe rupture. Mechanism of injury usually occur with blunt, penetrating or perforating object. Often globe rupture is obvious on exam, but sometimes can be more subtle. Symptoms: pain, greatly decreased vision, diplopia, teardrop pupil, prolapsed iris, hyphema. Focus on visual acuity and extraocular movement for any muscle entrapment. So this is a case of globe rupture with orbital fracture. So goal is to avoid any increase in intraocular pressure, shield the eye, pain relief please, antiemetics, NPO, tetanus prophylaxis, broad spectrum IV antibiotic, urgent USG, and repair. This is a case of globe rupture. There was a horseshoe-shaped scleral tear along the border of inferior rectus. I repaired it, and the post-op results are satisfactory. Now the orbital floor fracture. Mechanism of injury usually blunt force. The weakest area of the orbital bone is the orbital floor, maxillary roof, also known as blowout fracture. Sign and symptoms: eyelid swelling, ecchymosis, anophthalmos, ptosis, diplopia, anesthesia of the cheek, inability to move the eye upward. So this is the case. You can see the restriction of elevation. So because there is entrapped muscle and orbital content in the floor, fracture floor. So now the management: tetanus prophylaxis. Surgery is not always indicated. Arranging ophthalmology follow-up for the possible surgical repair. Surgery is most commonly performed in 7 to 14 days. Indication for surgery is entrapped muscle, facial hypoesthesia, symptomatic diplopia, not improving with over time, large floor fracture leading to enophthalmos. Observation: in case of minimal diplopia, good ocular movement, no significant enophthalmos. Prophylactic antibiotic can be given to prevent deeper infection. Tell patient to avoid blowing their nose. Now comes to hyphema. Blood in the anterior chamber occurs 70% of the time in the pediatric population. Majority of hyphema have less than 50% of anterior chamber filled with blood. Sign, symptom: pain, decreased vision, injected conjunctiva. The following clinical grading is there. Grade 1, less than 1/3 of the anterior chamber. Grade 2, 1/3 to half of the anterior chamber. Grade 3, half to less than total. And then grade 4 is 8-ball hyphema. Now the complication of hyphema may be secondary hemorrhage, corneal blood staining, optic atrophy due to prolonged raised IOP, anterior posterior synechia. Prognosis is usually come if the hyphema grade is less. Now comes to management. Elevate the head of the bed 30 to 45 degree. Eye shield, pain control, diclofenac or aceclofenac. Avoid aspirin, ibuprofen because they have antiplatelet effect. Hospitalization may be required if there is a chances of risk rebleeding is more, hyphema grade is 2 or higher, or IOP at the time of presentation is more than 30. Topical cycloplegic atropine is preferred. Topical or systemic steroid can be given, but loteprednol or fluorometholone is preferred because in dexa or prednisolone, chances of rebleed is high. Anti-glaucoma. Then there is a case of subconjunctival hemorrhage treated with topical antibiotic and lubricant. This is a case. You can see the restricted. This case has restricted movement and eccentric proptosis. This is a case of retrobulbar hemorrhage. So mechanism usually involve blunt or penetrating injury. Sign and symptom: acute proptosis, subconjunctival hemorrhage, decreased vision, pain, limitation of ocular movement. May lead to loss of vision because of central retinal vision occlusion. So management is IV mannitol, IV steroid, lateral canthotomy. So now comes to the true eye emergency. That is the chemical injury. You can see a limbal ischemia and large epithelial defect. There is a Ruppel Hall classification. So no history, no physical examination. Copious irrigation is key. 1 to 2 liters of saline or lactated ringer. Immediately begin irrigation for 30 minutes until the pH of the eye comes to neutral. Time is of essence with chemical burn to the eye. Acid burn cause coagulation necrosis, but less harmful. Alkali burn cause liquefaction necrosis and penetrates deep into the ocular structure. Lime is the most common. That is commonly known as chuna is the most common form of injury. Other is drain cleaner, cement, and fertilizers. So after 30 minutes of copious irrigation and neutralizing eye pH, visual acuity assessment is done. Fluorescent to check the epithelial effect. May require later AMT, corneal or limb transplantation. So what can we do to save the eyes? Prevention, prevention, prevention. Almost 90% of eye injuries could have been prevented or decreased in severity with better education, appropriate use of safety eye wear, and removal of common and dangerous risk factors. Education, education, education. Education, educate our children, family, and school about the importance of safety eyewear. So the summary, the eyes are very important. The eyes are very complex. Ocular injury is the leading cause of preventable vision loss in blindness worldwide. Using a systematic approach to the eye exam is best. Ocular trauma can be mild or severe and lead to blindness. When in doubt, give a tetanus shot. Over 90% of eye injury can be prevented with education and safety wear. Thanks.